So thank you so much for the invitation. My name is Chen, and I'm a machine learning lead at Google Health. So very happy to be here to share with you on some of the works that we're doing at Google. I think there's a chat function within Zoom. If you have any questions, please feel free to type in the questions during the talk. I'll try to answer them in the meantime. Or if I cannot get it during the talk, then I'll try to get to the questions at the end of the Q&A part. So before going to the details today, I'll talk about the title is called Evaluation of AI on a Reference Standard Based on Subjective Interpretation. While I was preparing, that's the initial title that I provided to Wilson, but during the preparation, I would like to actually talk a bit more. So I add two words after that, it's called and beyond. So how do we go beyond that? So there's actually two parts of my talk. The evaluation part and beyond. So before going to the details of the talk, let me start with a high-level overview of the work that we do in Google Health. We are a team within Google Health that specialize in medical imaging analysis. The mission of our team is to increase the accuracy and availability of medical diagnostics. And we have been working in this space for many years, started with one of our earliest work that you might have heard of is the work of detecting diabetic retinopathy from fundus images that was published in JAMA in 2016. So our work spanned across many different areas, including radiology, including X-ray, mammography, CTs, ophthalmology, digital pathology, dermatology, oscopies, and we also have a lot of work we call novel signals, trying to detect hidden signals from medical imaging data. So let me just start with a very basic healthcare AI development 101. I think many of you are familiar with, but just let me go through it to set the stage and to make sure that we are all on the same page. I will use the example of the study, which is the study of predicting diabetic retinopathy using the deep learning algorithm that was published in 2017. So the AI healthcare AI development process always typically starts with there's a training set. Here we have a data set, which is 80% of the development set, including 100,000 images. We use the images as well as a label, and then we train a machine learning model. This is what we call a training phase. Then there's a tuning phase. The tuning phase, we use 20% of the development set, roughly 25,000 images with the labels, and then we take the machine learning model from the training phase, then we evaluate the model on the label on the tuning set, and then we update the hyperparameter, and we do a loop like this. Once we are happy with the model, then we move on to the testing, or we call it a clinical validation. We take the model that is trained, and then we evaluate it on a clinical validation data sets, ideally from different sources. In this particular study that we published in JAMA, there are two different data sets that we used. And then we have a performance metrics. There's the development data sets contain training and tuning sets, and there's a clinical validation sets or we call it a test set. So among all of these process, one of the key aspects is the labels. And this is the focus of today. Labels often comes with varying levels of quality. And how should we think about labels when we use it for training, when we use it for tuning, and when we use it for testing or validation? And this will be the focus of our discussion today. Before going to the discussion, let me just clarify a few terminology. I think we often use the term label or annotation interchangeably. In supervised learning, this is kind of like the insert portion of the example provided by the annotator. And we also talk about the notion of reference standard or ground truth. The difference between when we are using label annotation as terminology or reference standard / ground truth is because when we say reference standard or ground truth, usually imply that it is to some extent kind of the best available method for establishing whatever we are trying to predict. And reference standard is a common term that's used in the clinical literature, and ground truth is commonly used in the machine learning literature. So I think many of you might know that or have run into the scenario that the real world data is actually pretty noisy. And let's start with some of the real world examples of the label noise and see what do we see in the real world data. So today I'll use the application of diagnosing prostate cancer in the digital pathology domain as an example. So let me start with like what is the motivation for us to initially work in the space of prostate cancer in the digital pathology space. Prostate cancer is a leading cause of mortality for men. 1 in 9 men will be diagnosed with prostate cancer in their lifetime. In the current clinical workflow, pathologic review of tissue is the standard for diagnosis and deciding the downstream treatment and patient management plan. So what does a pathologist do when reviewing prostate cases? They look at the tissue slice, and then they categorize every location within a slice according to a system which is called Gleason pattern. Gleason patterns is illustrated as an image on the upper right. It categorizes the glandular structure according to its level of differentiation from Gleason pattern 1, which is the most well differentiated, to Gleason pattern 5, which is the most poorly differentiated. Gleason scoring is a highly subjective process, and it is known that it suffers from very poor reproducibility. With an interpathologist, they score this at the level of 20 to 50%. And this is where exactly we think AI can be the most helpful with, by having a very objective AI in assisting clinicians in doing the diagnosis. Hopefully it can help with reducing the reproducibility. And I talked about the high number of discordance between pathologists. Let's actually look at some of the data about this. What we did is we performed a study. We asked pathologists, provided them with a prostatectomy slide, asked them to actually annotate the data, and we would like to look at their annotation. So we asked pathologists to annotate the data. If it's benign, circle them in black. If it's Gleason pattern 3, circle them in green. If it's Gleason pattern 4, circle them in yellow. If it's Gleason pattern 5, then circle them in red. And this is the data from the very first pathologist. You see that it's mostly Gleason pattern 3 on the left, Gleason pattern 4 on the right, a bit at the bottom, and there's some Gleason pattern 5 at the lower corner. This is the second pathologist. They are all US board certified pathologists, and you see that this pathologist annotated every single location within the slide as Gleason pattern 3. So now you see they are all US board certified pathologists, and there comes to a different annotation, even on exactly the same data. And this is a third pathologist. It's similar to the first pathologist. It's mostly Gleason pattern 3 on the left, 4 yellow on the right and the upper part. There was some Gleason pattern 5, but then for this pathologist, it's missing. Someone might say that, oh, pathologists, they don't actually do diagnosis in this way. They don't zoom all the way in and draw polygon on the slide. That's just not their diagnostic workflow. It's not natural. You have to look at the big picture. So that's also what we did. We did ask them to provide an overall slide level grade. Slide level grade for pathologist 1, it is slide level grade 4+5, means it's mostly Gleason pattern 4. You see mostly they're yellow, but then the +5 means there's a little bit of the Gleason pattern 5. But for the second pathologist, it's all 3+3, means the primary pattern and the secondary pattern are both Gleason 3. And the third pathologist is similar to the first one, is also 4+5. Clinically, 3+3 will very likely undergo active surveillance for a patient. That means the patient doesn't really need to do immediate intervention. Basically, they go back home and they come back to redo a surveillance maybe in a year or in 2 years. But when it comes to 4+5, it's often likely require a more active intervention, potentially also including the removal of a prostate. So you can see this is the real world data noise. Then also lead us to a lot of thinking of, with this level of noise, how should we train a model? How should we turn these annotation into labels for model training, for tuning, and most importantly, for validation? Like no matter how we train the model, the validation data, and especially the validation labels need to be of really high quality for us to have a good understanding of what does the model perform. In another study that we done that was published in JAMA Network Open in 2020, what we did is we asked a group of 20 pathologists to review a set of 240 cases, and this is the results all in a single figure. Let me walk through this figure. Every single row is a single pathologist review. Every single column is a case. The bottom text is the ground truth. So here is no tumor, here's grade group 1, here's grade group 2, here's grade group 3, and here's grade group 4, 5. And the different color indicate the pathologist review on that particular case. So for all of this, you can see they are all non-tumor. If all the pathologists are 100% accurate, it should be all gray. But you do see there are quite a amount of pathologists, they grade cases as grade group 4, 5, or at grade group 1. Look at, for this cases, they're all grade group 1. Some of the cases, pathologists grade them as non-tumor, some of them grade them with a higher grade. And you can see, right, this is like a very clear visualization of a label noise. But these noise is also not that the pathologists are not doing a good job. They all are evaluating, diagnosing the slide, but this task by itself is highly subjective. And these level of subjectivity, why is it problematic? So for these data, let me use a toy example as an illustration. So here is a toy example. On the leftmost, what you see is the AI's diagnosis. For blue means there's a disease that's absent. For red, that means that disease is present. So for this toy example here, there are overall 10 patients. 2 patients has disease presence and 8 patients has disease absence. Let's say we have 3 grader and they all have the grader's annotation. So for grader number 2, by comparing this with the AI, you'll see that they have 70% of concordance between AI and the grader number 2. Grader number 1, grader number 2, there's some variability here, is roughly 70%. And grader number 3 and grader number 2, they also have roughly 70% of concordance. But by evaluating AI against grader number 1 or grader number 2 or grader number 3 actually leads to very different performance measure, which can range from, in this toy example, range from 40% to 100%. And here the discussion is all about, given that we know that there are a certain level of noise when it comes to the annotation process from different pathologists, from different clinicians, how can we design a process that makes it better in reducing the variability so that we can actually have a better estimate of how well does the model perform? So in this part, we'll discuss what we call the ground truthing process. What is the ground truthing process? Ground truthing process is a process of obtaining a ground truth, which is a machine learning term, or obtaining a reference standard. Generally, there are 3 main approaches when it comes to thinking about obtaining a ground truth. One, like the typical way people do, have a single clinician review the cases and take the annotations and then use that to evaluate the model. But as we just seen, right, there are noise that's within the annotation from the clinicians. So there are other ways. There are 3 approaches that we are proposing that can help with reducing the noise. So first will be increasing the expertise of the graders. Second is to increase the number of graders for each case. And the third is ensure disagreement resolution process is unbiased. So let me go through these one by one. So for the very first one, it's fairly straightforward. Instead of getting, let's say, a general clinician, we can find expert. There are many studies have shown that expert tends to be more accurate than general clinicians. Expert with more training tends to be more accurate, and their diagnosis tends to be more consistent and reproducible. The benefits is the expert is more likely to be correct, but the challenge here comes with expert. There are fewer experts than the generalist. So what we did in one of our earlier study is we have a group of general pathologists. They first review the cases, and then we have a single expert to provide the final diagnosis while having access to the group of general pathologists. A second approach here would be to just simply increase the number of graders for each case. Instead of having one clinician reviewing the case, you can have 3 clinicians, you can have 5 clinicians, or you can have even 10 clinicians if it's logistically possible. The benefits here is it is oftentimes the easiest way to reduce variability based on statistics, increasing the n, the variance go down, and it also reduces the accidental errors like clinicians might miss something. But the challenge here is with the increase in coordination of the logistics becomes very challenging. The cost will increase drastically, and with more people, there are more voice in the room. There might be additional difficulty when it comes to reconciling to get the final reference standard. What we did in one of our earlier study that's published in JAMA Oncology is we have 3 experts. Comparing with our previous study in 2019, there's only 1 expert. We have, for this later study, we have 3 experts, and then we impose a majority vote process among the experts. People might say, oh, here we do majority vote, but is majority vote really the right approach? And this comes down to, there's like there are actually many different ways. Someone might take the majority vote, someone might take the median, someone might require a discussion to get a consensus. And this brings us to the third aspect of like, what is exactly the process for us with a group of annotators? How do we actually derive the final reference standard? So the third approach to ensure we have a better ground truthing process is to ensure that disagreement resolution process is unbiased. So one of the benefits is having an unbiased process. Oftentimes it can help reduces the effect of having kind of like the loudest voice in the room. Additionally, like by considering using either majority vote or consensus or discussion or asynchronous discussion, synchronous discussion, there are multiple ways when it comes to the decision-making process. The challenge here is, again, coordination of the logistics is pretty oftentimes when you have a large number and you have a fairly complex process, it becomes quite challenging to coordinate the logistics. And another is sometimes the expert, they agree to disagree. And when there is a deadlock, then we need to also have a way to make sure that we can come to a final resolution. So these are just 3 high-level approaches of helping with improving the ground truthing process. But as a machine learning scientist, we always think about that, how do we know we have done a good job when it comes to designing a ground truthing process? So here, our perspective is, I think the key here is to actually measure the reproducibility of the ground truthing process itself. So for example, we might want to measure intra-panel concordance. Given the same panel and a same set of cases, we may want to measure having the panel review the cases twice with a washout period in between to see how consistent are the panel and the process. Or we may also want to measure inter-panel concordance to see, given 2 panels consist of 2 different groups, how often do the 2 panels agree? Having higher level of concordance will help us get to much more accurate when it comes to the evaluating the machine learning model's performance. So let's go back to the toy example. This is an example that I've just shown. In this scenario A is we have 3 graders. Let me show up in the scenario B is, let's say if we have 3 experts. Between scenario A and scenario B is between expert, we assume that the concordance between expert is lower. And here you can see the level of uncertainty of measuring the AI's performance with 3 experts as the reference standard reduce comparing to the scenario A. And scenario C is assuming that we have 3 panels, which has even higher concordance, then this has the lowest level of uncertainty. So going from, for the illustrative example, from a single grader to a single expert to a single panel, we assume the increased concordance between the ground truthing process. The more concordance the process is, the more accurate, the lower uncertainty it will be when it comes to measuring the AI's performance. So going back to our working example of the prostate cancer, just let me walk through how these get into play in the studies that we actually did. So in 2019, for the prostate cancer work, we developed a deep learning system that's mimicking the pathologist workflow to produce the final Gleason rate. The model goes from right now, look at a fairly standard, given the images, get a convolutional neural network, predict a classification heat map, summarize the heat map into a feature, and then we use the nearest neighbor to get the number of grade group. So we use the approach of having a group of general pathologists review and having an expert do the final review to obtain the final reference standard. And we show that the system is able to outperform a group of 29 general pathologists. And this is in the scenario of having a single expert review. In 2020, our study is we did the work on, instead of prostatectomy, we move it on needle core, which has less tissue. Here, we improve the reference standard by increasing the amount of expert from 1 to 3, and now we use the majority vote of 3 experts to provide the final reference standard. And what we have shown that is that by using this set of labels, we are not only be able to show that the model outperforms a group of general pathologists, now we can also show that the model is getting close to the experts levels performance. So in summary, I think I've talked about the work of how should we think about the ground truthing process and how can we improve it, how can we measure it. But let's now talk about then what's beyond. So far, we are all talking about developing machine learning models with subjective reference standard from clinicians. But is there a way for actually go beyond that? We know that human annotation is oftentimes very straightforward to obtain, although it might be costly, time-consuming, but oftentimes it is still suboptimal, just because of the variability there. So maybe let's step back a bit and think about how did we just put machine learning on the side, just step back a bit and think about how did we come up with the cancer grading guidelines, such as the Gleason pattern grading guideline. So for example, the Gleason grading guideline was invented by a person. The person is called Dr. Gleason. Dr. Gleason reviewed many prostate cases, understood the outcome of these patients, and created the Gleason pattern, which have been repeatedly shown that it's to be highly prognostic, which means that it can predict patients' outcome pretty well. And that's how the fact that it can predict outcome pretty well make the Gleason pattern useful, because outcome is what matters, and it is the key information that clinicians use to decide the downstream patient management. We know that subjective reference standard will always be imperfect because it is subjective. Then, therefore, it prompts us to think about, can we evaluate the AI on outcome directly instead of evaluating them on the subjective reference standard? So this is a study that we did in 2021. We curated a data set with 2,800 cases with a median of 13 years follow-up. The cases come with the pathologist provided grade group during the clinical diagnosis. And then we evaluate the previously mentioned Gleason grading model versus the pathologist provided grade group directly against outcome. And then we show that the AI system actually is able to predict prostate cancer specific mortality a lot more accurately than the pathologist provided grade group. This is actually a very exciting result because it actually shows that the Gleason grading algorithm, which is trained on human provided annotation labels, is able to do what matters the most to predicting outcome better than a clinician's provided Gleason grade group. But let's also step back a bit more. Is here on the left, here's the illustration of what I've just mentioned, right? Of Dr. Gleason invented the Gleason pattern. Well, that's like the original one. There's have been a lot of evolution, but basically, based on cases and outcome, human come up with a grading scheme, and then having the grading scheme being used by the community and for the community to grade cases. If you really think about this, it feels like this is kind of what a machine learning system can also do. Instead of having human looking at cases come up with a proposal of what is the patterns, maybe is it possible for us to feed a bunch of cases with their outcome to the AI system, for the AI system to discover what are the patterns that are like actually useful, or to do risk stratification to help inform the downstream patient management. Because you can also argue that potentially an AI system can actually see many more cases than a human can possibly see. So this brings us to a series of work that we have been working on, which is with a goal to directly predict outcome. So what is the problem setting when it comes to the direct prediction of outcome from histopathology slides? The input is we have a set of cases, and for every single case we have a set of slides. We want to train a machine learning model that is directly predicting survival, and here is time to event, the probability of the patient being alive at the time t, given the case slides. The benefits here is we're directly predicting outcome, and as we have discussed, outcome is what matters eventually. Additionally, it also helps with potentially sidestepping the need to having pathologists to do a lot of annotation, and then it is a very time-consuming and oftentimes expensive process. The challenge here is there's very limited amount of training data. Previously, in the development process of having a pathologist to outline the to annotate the slides, actually for every single slide we do the patch-based approach training. We can split into many patches. Every single slide give us, for example, 100,000 of peer input-output pairs. But when it comes to directly predicting outcome, every single case is an input-output pair, and we suddenly reduce the amount of data from hundreds of thousands to one for every single case. The second challenge here is, even if we can train a model that is accurate in predicting outcome, it's also not quite sure how can we based on the model figure out whether the model is actually learning, and then using that to, as I mentioned earlier, to inform human of like discovering the new medical knowledge. The interpretability, the unknown signals part, even if the model is accurate, how to interpret that becomes particularly challenging. But let me just start with how are we doing this? Which data set do we do this? Initially, we started with the TCGA datasets. I think many of you might be familiar with TCGA dataset. We utilize across 10 different cancer types and roughly 5,000 cases. We develop a weekly supervised learning approach for directly predicting disease-specific survival. So it is a combination of convolutional neural network with average pooling and with a fully connected layer at the end, and we have a customized loss function and directly predicting time to event. So very briefly on the results, if we look at the deep learning system, we can see that the deep learning system is able to risk stratify the patients into low, medium, and high risk. For the baseline that we compare with is age and cancer stage, which is also doing a pretty good job at doing risk stratification. We also combine the baseline in the deep learning system, comparing the first figure and comparing the second figure and the third figure. You might see that The third figure is able to do slightly better risk stratification, suggesting that the deep learning system is capturing some of the information that is complementary to what the baseline is capturing. We look at the KM curve for substratify within a stage. As you can see, for stage 1 and stage 4, the deep learning system is having a hard time to stratify the low risk group from the high risk group. But for stage 2 and stage 3, the deep learning system is able to meaningfully stratify the patient into two groups. And these are like very early results, and that's like early encouraging results that demonstrate that there's a feasibility of directly go from the raw image to outcome. And then later on, we collaborated with University of Graz in curating a much larger data set of roughly 8,000 cases, and this time only all on a single cancer type, which is colorectal cancer. And we focus on the intermediate risk group of the colorectal cancer, typically as which is stage 2 and stage 3, because for stage 2 and stage 3 patients, the treatment decisions can be particularly challenging. And this is the high-level diagram of the study. First, we have an AI systems that's doing risk stratification, which is the same system as I mentioned earlier in our previous study. Go from it, input a set of images per case, as well as the prognosis per case, train a deep learning systems to do risk inference, and then to derive a final prognostication. Let me skip the bottom part, which I'll get to later. So on this colorectal data sets, we have 2 independent validation data sets on both stage 2, stage 3, and stage 2-3. We can see that the deep learning system can meaningfully stratify patient within each stage. So now we have shown that the deep learning system is able to directly predict risk stratification, is able to directly predict outcome. But now what? Now comes to the question is, so now the challenge is, what can we learn from the system? And this brings us to the topic, I think, of many people's favorite is interpretability. And interpretability, generally the way we think about interpretability is there are two different general thinking. There's like the first one is when we think about interpretability is that there is already a known prior that human have in mind, saying that, oh, this feature is associated with something, and I want to see whether the model is capturing the prior feature that we already are expecting. And there's another thinking is we are wondering whether model can discover some unknown features that we are not expecting, we don't have any prior. And there are different approaches when it comes to these two different thinking. The latter one, like the approach is to identify previously unknown features or previous features that the developer aren't expecting. That is what I previously mentioned has the potential for us to discover new medical knowledge. But just let me go through the first approach first. There are approaches to identify known features. There's one way is using a saliency map. A saliency map is an approach to highlight regions within a slice, saying that, hey, these pixels are most informative for doing this prediction. So for this particular example at the upper right, is that there are, this is the chameleon challenge. I think some of you might know. The chameleon challenge is to predict whether there's tumor or not within the lymph node pathology sections. Pathologists typically look at the nuclei and say, oh, there's kind of a bit of pepperish, and the model actually also highlight nuclei. So there's like, oh, we are already expecting the model to highlight nuclei, and the model actually does highlight the nuclei. So we say, oh, this is interpretable. The other way people have been doing, one way is called TCAF, which is a research from Google, saying that we can test the model with some particular concept. The most canonical example here is having a zebra model and to test how important is the concept of stripes for the model is using the concept of stripes to predict a zebra or not. There are the approaches to help identify unknown features. One way is to use saliency map. It's like you just run the saliency map onto images, but from my perspective, it's oftentimes kind of reading the tea leaves. Because if you don't have the prior, it becomes like whatever the image is highlighting, then you kind of, it becomes like human trying to interpret or tell a story about what's being highlighted. The approach that we take in the study is we use a clustering, and specifically we use clustering with image similarity model. So what does that mean? We use a very specific type of neural network, which is optimized for image similarity. The neural network, given it will put images into embedding space, and when looking at embedding space, they will look visually very similar when they are very close in the embedding space. So what we did is we ran this image similarity model on the data, on all the patches within the data sets, and then we clustered them into a group of clusters. And then we run our previous prognosis model on these clusters, and we show on the right, we show now the images from the cluster as well as the prognostic score from the clusters. There are two observations. First of all, if you look at every single row, which is the clusters, you'll see that images look very similar to each other. And this is something that we can ask pathologists to look at these images and associate a semantic meaning to each clusters. And this is, it doesn't require a model to have a prior of what are we looking for. Basically, we're just simply doing clustering, get the images that look similar together, and having pathologists to tag or associate semantic meaning to see what's actually highlighted in these clusters. And the second is, for the first cluster, we also discovered that it had a very high prognostic score. It can predict risk stratification pretty well. So then we actually do a study as we take the first cluster, we have a group of pathologists interpreting it. We come up with a name called tumor adipose feature, which is tumor and fat kind of bundled together. And we show that just simply by quantifying the amount of this feature, which previously is not well known, the system can, the deep learning, the quantitation of the task feature is able to show risk stratification. This is a super exciting result because with this approach, we have used machine learning system to discover a previously unknown morphological feature that is highly associated with prognosis. And now we are also doing further research on this to try to understand whether human can create a grading guideline and to based on these features and then to reproduce the risk stratification. If so, you can think of this as similar to taking the prostate cancer example, is similar to having a machine learning system to automatically, potentially automatically discover a grading scheme like Gleason pattern. Okay, so to summary, I think today I talked about two parts. The first part is about improving reference standard based on subjective interpretation. There are general 3 approaches to improve the ground truthing process, including increasing the expertise of number of graders, as well as ensuring the disagreement resolution process is unbiased. And how do we know we have done a good job? It's by measuring the reproducibility of the ground truthing process. And then the second, I talk about the beyond reference standard based on subjective interpretation. We should all think more deeply when it comes to when we are designing annotation tests. Think about what is the annotation is for. Is there potential signals that is beyond the subjective interpretation that we can actually just let the model learn end to end? Like as a machine learning scientist, in the deep learning paradigm, we are always trying to go from end to end, right? But is there something that we can, for cancer, what usually ultimately the matter is always outcome. So therefore, can we just go from the images and let the model learn end to end to the final outcome? And additionally, leveraging AI, there are opportunities to discover new medical knowledge by going beyond the subjective reference standard, because by staying with the subjective reference center, we are still staying with the current medical knowledge, but by going beyond, using the signal that ultimately what's matter, give us the opportunity to potentially use AI system to discover new medical knowledge. And this is something that is very exciting. So these are the papers that I've touched on from our group, and these are the and if you want to read more of other publications from Google Health, here's a URL. You can see all the publications there. All right, that's all I have for today, and I'll take questions.